someone who's incredibly healthy by every other metric may be aging much faster than what we realized.
Once the immune system starts to age, and I'll just sort of define that more, then that kind of what pushes aging of other things. So you don't, like, unless you have a predisposition to chronic disease early on in your family history, immune system really what goes first.
Just because you feel good doesn't necessarily mean that you are on the longevity pathway. And some of the interventions may actually be overdoing it in certain areas. And so
Exactly. And even not just longevity, but even the health span. Like, it just because you feel better in the moment, it doesn't mean it's not breaking down your immune system and setting you on the worst path. Like, feeling better in the moment versus 10 years from now is not the same thing. It's one of those things where you have to think about, what is it in my life that could be causing this? It's like the pill is not always the answer. And sometimes, getting 8 hours of sleep and, letting things go is all you need.
Natalia, so good to have you here on the Ageless Future podcast. And you're a true pioneer. When I heard you speak at Da Vinci 50 and you're talking about rapamycin, and then you showed all the images, all the work you've done with cellular senescence, and really understanding the issues from a nuanced perspective with longevity therapies, I think a good place to start would be just framing the story of aging. Like, how does the immune system age, and how does it relate to aging?
Thank you, Regan. It's great to be invited on your podcast. It's a really interesting way, sort of kind of the story developed and the way people think about aging, because back in the day, we sort of thought that aging is failure of organs. So you have kind of these chronic diseases and things kind of start to deteriorate. In the last few years, an immune system kind of was treated as one of the organs. Like, sometimes your immune system can fail and you can have, diseases like, bronchitis or pneumonia or something like that. So in the last few years, with all the proteomics and all the sort of omics approaches, it became really clear that immune system is aging. What drives aging is the aging of the immune system. So once the immune system starts to age, and I'll just sort of define that more, then that kind of what pushes aging of other things. So you don't, like, unless you have a predisposition to chronic disease early on in your family history, immune system really what goes first. So, and we routinely see it in, people who are 20 or 30, you start seeing sort of that sterile chronic inflammation creep up. And I think that's sort of, it's hard to kind of think about it that way because you don't feel like you're aging when you're 20 and 30, but your immune system does. But I think the flip side of that is immune system is super dynamic. So if you know that something is happening in the immune system, you can actually do something about it before you get your first attack or you have cancer. And so I think it's sort of, it's a challenge to be able to see it. And that's sort of, we worked on for a long time to develop a test to do that. But I think it provides such a unique opportunity and such an important opportunity, especially in the longevity space where people are very interested in prevention and sort of understanding how to tackle these things. And then on top of that, I would just comment that with the, like with therapies just exploding in the last few years, like, it's really hard. There is no one size fits all. Everything has a risk. Everything has a benefit. Understanding what therapy would work for you and not, and why you should and should not attempt it, I think is also really critical, because longevity cannot be proven. And so you don't know if it worked for your longevity or not, but in the meantime, it can give you a side effect. And so trying to understand and monitor, like, are you a good candidate, but also monitoring, I think is really critical. And so that's where we take this sort of, we think of the immune system aging as aging, but I think this idea that it's dynamic and it helps you kind of see where you are, among your peers and among general population. To your question of how immune system ages, it's sort of, it's very complex. Immune system is very complex in general. And in the sort of, there are lots of things happening. There are different cell types that change counts. there is sort of like your thymus starts to degrade, so you don't no longer producing stem cells, so you just kind of have the stem cells you have. So if you have infections in early life, like UBE and CB, they continue to exhaust your immune system. So there's sort of a lot of things are happening, like you enable the most common sort of presentation is you're unable to respond to vaccines as efficiently as when you were younger. But in a nutshell, what's really important is your T cells. So your T cells are the soldier army that is holding your immune system in check, both so it can react to things as needed, but it also doesn't overreact. So it's a really important response to be able to react to threat, clear the threat, and then come back to the baseline. And so that ability to be and react really quickly and not some cells react, but other cells cannot. And so you're kind of lingering, you'll stop in that state where you create chronic inflammation. So ability of T cells to quickly respond to things and quickly come back is really critical. And so what we're measuring is the domains of the immune system in T cells that are kind of do these things, that are all these sort of functional domains that are important for this response. And that's, I mean, again, it's sort of at the end, it ended up being really some picture, but it, with a clinical sort of explanation, but it took a while to get there. But I think it is really being able to measure it provides you such a clear example of where you are and who you go.
And I think it's interesting because the T cells, like, in aging, we've looked at like the 12 hallmarks of aging, and you can go through, immunosenescence would be one of those. And then you've got stem cell exhaustion, loss of nutrient sensing, loss of proteostasis. We can go on, but what you've been able to isolate through your research is T cell function.
Mhm. Yeah. And so T cell function would fall into the immunosenescence umbrella. But realistically, so when people think about the immunosenescence, what they mean is CD4-CD8 ratio changes.
Yeah.
But it's just like with frailty. By the time the ratio changed, your immune system is essentially non-functional. You're super frail. So it's not a dynamic enough measure to be able to actually capture the early decline. And so, yes, immunosenescence happens, but if you look at the definition of immunosenescence, if you measure just that, then, I can tell you have an immunosenescence if you get a cold every 6 months. Like,
Right.
you don't need to really measure that. So being able to capture early events is really important because that's where, just like with any disease, that's where you can actually do something about it with minimum effort.
Well, and that's where Sapir, the technology that you've created that actually allows us to see the health of the age of our immune system. It was pretty shocking just looking at my results. Natalia just gave me some good news and bad news at the same time, because I do a lot of interventions. As many of you know, I'm experiment with my body. We look at blood labs, we look at metabolomics, we're looking at gut tests, RGCC for clients who are concerned with cancer. But this one just takes it to a whole nother level, is what I realized. And also in having about a dozen of my clients run their labs with you. And there's some denial that happens when because someone who's incredibly healthy by every other metric may be aging much faster than what we realized. And we could be using the wrong inputs. And any biological system, there's a negative and there's a positive feedback system. And what your research does is helps us get very clear on what the interventions are actually doing. Can you explain how you got to that level of precision?
Thank you. And I think that's sort of what separates us from a lot of other sort of biological age tests, if you wish. We don't like to think of it Sapere as biological age tests, but kind of in the same group, where we put a lot of effort into asking what would be clinically relevant, what would be helpful. If you know this, can you do something about it? If you know this, does it give you any more information than what you can get, sort of with traditional clinical labs, like even the most sophisticated ones? And then on top of that, we also worked on this idea, which is not groundbreaking, but precision of measurement also matters. So if your system is really noisy and your measurement of 2 p.m. versus 5 p.m. could be different, that's not a good measurement. Like, you have to make sure you're capturing measurements that are stable. And And then the third is the closer you are to the actual measurement, the better the system is. What I mean by that is, like, for example, if you measure glucose and insulin, you're measuring glucose and insulin. If you start looking at hemoglobin A1C, or you start looking at methylation surrogates of that, like you're walking away from the actual measurement. So you start to introduce noise to the system. And so the further away you are from the actual measurement, the more there is error. And so if you are looking at interventions and you're asking, is something working or not, how much of the change is actual intervention? How much of it is your lab error? And so being able to carefully layer those things on, so sort of back to kind of to what we do is we measure the actual markers, the actual gene expression markers of T cells that give the function that we're measuring here. So we're not measuring surrogates. And then on top of that, we know those markers are stable because we've tested other markers and not as stable. So we know those markers are stable until we do something. And T cells in general, like if you think about the T cells, they give you lifetime immunity. So T cells are generally very stable, unlike monocytes, unlike even B cells, like they don't fluctuate. So it is a very stable measurement. And then, obviously it needs to sort of scientifically be valid target. But it's a lot of work to get it done that way. But I think it's sort of having the clinical input of what you guys already know. We don't need to duplicate creatinine measurement in some other fancy rate or, whatever measurement, right? So to be able to complement what you guys do, especially with functional assessments, to be able to complement, I think was really important. And that's where I think the success comes in. Because if we can do that, we could give you the tool for something you cannot see right now, but then you can plug it into your workflow of things you can see. And you have sort of this clinical gut that doesn't feel right. What is wrong? But if the test is a black box, then you can't judge what's wrong. Like you can't judge if it's right or wrong. So we try to be as direct with measurements and without having black boxes as possible. So then you can kind of look at it. And we routinely have that when we talk to clinicians where they'll be like, I don't understand why this patient has a really high chronic inflammation. Like with one case, they have really high chronic inflammation. It doesn't make sense. They're super healthy and CRP is this and, liver enzyme is that, and everything's fine. And we're like, but, they do have familial hemochromatosis, but their iron is at the good level. I'm like, well, you also have 50 years of history of familial chromatosis. The iron is already in tissue. It's not in the blood. You're not going to see it. But in tissue, and it's creating a lot of inflammation. Like, it's a direct measure. Like that is the answer. The answer is the answer. Yeah. So to be able to see that, whether there is a therapy or not for a specific thing or not, is a different story. But for a lot of these things, there is. And so, but again, like Brian Kennedy from Singapore talks a lot about this, that stacking interventions is not great because none of them are tested at the stack. So you actually, when you stack things, you don't know, like, are they amplifying each other? Are they negating each other? Is it damaging? So to be able to do multiple interventions sort of in a, one-off kind of way, but then to be able to track and then, okay, this doesn't work for me, move on to the next. That doesn't work for me versus trying 4 to 5 things at once. And it's not just the cost, but it's like you actually don't know. You might only need one thing or you might run out of those things. And so it just makes things, as we all work on our health and longevity, just makes things a lot more efficient.
And so if we go right down to the measurement, it's the T cell that expresses a certain gene, and that's what you guys are testing. You're going right to that interception of the communication. And I think that's powerful. That's what most things is too far removed. Like, what would you say the biggest downside is of relying on telomeres, for example, for biological?
So telomeres, So the reason, telomeres are famous because sort of, there's Nobel Prize and it's one of the earlier measures of aging. So they're famous for that. But telomeres, not everybody has short telomeres, not like in general in the population level telomeres shorten, but there's also, everybody has different levels to start with. So if you don't know where you start, that also is not helpful. The biggest thing with telomeres is there is such a huge variation in the population that unless you have a genetic disease that gives you short telomeres, where there are some kids who have genetic disease, you're obviously an outlier because you're sort of 3 standard deviations out of the range. Everybody else in the middle is kind of on the population level. So it's really hard to say like back to the lab precision, right? Like, are you actually shortening or are you just bumping around? And also, so telomere shortening is what happens in senescent cells, but some senescence happens and telomeres don't shorten. So it's not a one-to-one metric of whether the event is happening or not. Same with DNA damage. A lot of DNA damage causes senescence, but you can have senescence without DNA damage. And so it's not anything. So cellular senescence is cells become old, so they become non-responsive to things, but they don't die and they continue secreting their inflammatory molecules, right?
Yeah.
So they create these pockets of inflammation in the neighboring cells, and because they secrete these molecules, and especially in the immune system, the molecules travel throughout the body, and you start seeing some senescent normal cells become senescent throughout the body. So being able to measure senescence tells you how many cells you have essentially. If you measure things that the senescent cells sometimes have and sometimes don't have, that you're kind of getting half a picture and you don't really know what the actual measurement was. It's the same where there are some sort of technologies where senescent cells have a lot of organelles, a lot of lysosomes, and they stain blue if you stain an X-scale. But a lot of other cells stain blue because they have organelles. So yes, blue cells are senescent, but also black. So in general, senescent cells can now be more than about 5% of all cells. It's incompatible with light. X-gal staining gives you a 40 to 60% count. So only 5% of those can even theoretically be senescent. So there's so much noise that, and if you're trying to look at the treatment and see what happened, you're not going to see anything. Or you're going to see something and think it's senescence, and it's just decreasing your lysosomal capacity. So it's being able to measure the actual scientific thing and to be as close to the measurement as possible. To me, in my opinion, is really important.
That's the key is separating the signal from the noise is kind of what.
Well, I think of it like clinically, right? Like if you want to know if somebody have a heart disease, I mean, yes, you can take their pulse and you can look at them and see, and you can put them on treadmill and kind of without measuring anything and just kind of see how they do.
Yeah.
Or you can measure. Like there's no better way than measuring direct function and trying to estimate by how, if the person is breathing heavy. Like it's it's sort of there are surrogates and they're helpful, but if there's a direct measure, it's always better.
Yeah, yeah, definitely. And so we did my test, and maybe you could share it so you guys, because I think this will help people gather better context around what Sapere actually looks at. And I like the non-biased way that you guys look at this. And so here's Regan. I'm giving full disclosure to share my my medical data because I learned so much from it. And so maybe you could explain to people what you're actually testing when it comes to going right to the T cell expression.
Yep. So SapereX test is a simple blood sample. So it's a single tube of blood that you collect, and then we isolate T cells, which is a really important step to cut the noise. And then we measure gene expression of various things. So when you sort of, as a dashboard, we give you two things. The way immune system ages, there's multiple processes that go within the immune system that ages it, right? So one of them is introduction of cellular senescent cells, so cells becoming senescent. And another one is a loss of immune resilience. So that's your ability of the immune system to resist things, like whether it's viral or bacterial infections or sort of chronic inflammation. So you can resist the infection and then suppress inflammation. So the immune resilience is really important. And so our metric is an longevity score, but basically that's ability of the immune system to kind of resist the new insult. And so for cellular senescence, we like it to be, so this is a percentile in population, and we like it to be kind of in the 20 to 60%. Below 20% senescence could potentially be a genetic risk for chronic diseases, such as cancer and heart disease, or it could be that you have a longevity gene and you're super optimized on your lifespan and you're doing well. And so that further testing would be needed to kind of distinguish the two categories. It's very different. So above 60% is not desirable because sort of you're above population average for sure. And so yours is slightly high. On the immune longevity score, we simply put it with 50 below. So the longevity score is 0 to 100. And so we say below 50 is not desirable. Anything above 50 is desirable. And so that's just a dashboard that kind of quickly shows you the two main ways in which immune system ages where you are at. And so your cellular senescence is a little bit high, your immune longevity is good. It's not 100, but it is definitely above average. So then if you look at cellular senescence, sort of do a deep dive into cellular senescence. So this is your value, it's a PCR unit, so kind of it's arbitrary units. And so you're about the average curve. So if we look at the curve, so first of all, if you notice, it's a logarithmic increase. So it's not a linear increase with age. About age 60 or so, it starts to speed up. And so this is, in this particular version report, it's about 1,200 individuals that were tested, of which 900 were clients in longevity clinics. So we've also done a lot of work with people who have chronic diseases and like cancer and get chemotherapy. So those are excluded. So these are healthy people, quote unquote. And so as you can see in your age group in general, your senescence is a little bit higher than we would like it to be. There are people in their 20s who have cellular senescence way higher than you, and then there are people in their 80s. So it is really super heterogeneous. Like I would say in every age group, anybody can be anybody. So really without testing, you don't know. And the reason sort of what I say is important is because, like I'm sure your audience is familiar with the concept at least of senolytics. And it's this, hot thing that everybody wants. But if you don't know where you are, do you know that, like, you don't even know if it works or not, and if it's the right dose for you and all, but also, like, do you even need it? Because your senescence is already optimized, why you get senolytic? Because all these things have risk. Or, like, even when we talked about stacking, like, you might be doing something else instead of doing the thing you don't need. So it's sort of you're just wasting your time.
Yes.
And then, so if you look in your particular age group between 41 and 50, like I said, you're in the 81 percentile, and the Z-score is 0.9, so you're about 1 standard deviation away from the average. And so, so it's less desirable.
Yes.
If we then look at the immune longevity score, so your immune longevity score, so like I said, it's from 0 to 100, your value is 64. Women tend to have a little bit better immune system, so they're about 10 points higher than men. So this is the average for men. When I say it's the average, I think you can appreciate that it is super heterogeneous. In theory, there is a trend line with age, but aside from people in their 80s who cannot be like in the really high category, it's super heterogeneous. So again, if you don't measure, you actually have no idea where you are in any age group. And so you are well above average. So you look good here for men in your group, but just in general, even in the population level, you look good. And so if you start to dig into the immune longevity score and try to understand sort of how, why is it 60 and not 40, for example, 20, or how, like, what is sort of, where are your areas for improvement? So T-cell exhaustion is one thing we measure, and it's a direct measure of T-cell exhaustion. And T-cell exhaustion it's a hot thing in cancer. So immunotherapies target T-cell exhaustion. And so that's the way for immunotherapy to work across all diseases, all cancers, regardless of origin, because you're targeting the immune system. And so that's sort of, there's multiple drugs that are used for immunotherapy, and some people respond, some people don't respond. So it's a very complex situation. But T-cell exhaustion is really important for your immune system to respond. It is what it sounds like. Your cells are exhausted. So they're not dead, like they can kind of respond, but they're sluggish. In the longevity community, where T-cell exhaustion becomes really important is there were a couple papers, there's sort of number of mouse papers and there's some human papers suggesting that longevity drugs like SGLT2 inhibitors, so like the clozin family, the canagliflozin and piogliflozin, and rapamycin, so those two drugs improve the immune system by targeting exhaustion. So they work for T-cell exhaustion. So the right dose in the right person will decrease T-cell exhaustion and therefore will improve immune system. So this is kind of the spot that a lot of our clinicians use to think about who needs the therapy, who can benefit, who is not going to benefit, and then track it as they administer therapies. Because again, both rapamycin and SGLT2 have side effects. And so just because it's a hot topic, if you don't need it, you're probably better off staying away from it. So you are in a 30 percentile, so lower is better. You're in a 30 percentile, you're half the score from average. So your T cell exhaustion looks good. This would also be elevated in people who have viral reactivations, your EBV and CV and all that. So that would be really high. Interestingly, it's also really high in people who over-exercise. So sort of, I used to be an athlete and I got to continue pushing myself the same way because I think I can. The T cell exhaustion is going to be really high. Senescence will also start to break, but T cell exhaustion is going to be really high because you're overtaxing your immune system. And so the second marker we look at is T cell differentiation autophagy inhibition. And basically what that is your T cells, when they come down from addressing whatever they need to address, they become memory cells. So they differentiate and they become memory cells. And so good memory cells then able to go back, they remember the infection. And so they're able to go back and do their job. Sometimes when they sort of wear out, certain things happen, they become terminally differentiated, meaning that they cannot go back to work. They're there, but they can't work. And they're sort of, a lot of times it happens because of chronic inflammation. So you have a lot of inflammation and you kind of memory cells just kind of, go out of their commission. And so that marker, so about 70%, 80% of your immune system is actually in your gut. And so a lot of times when we see this marker elevated, it's because of gut dysfunction. And especially as people get older in their sort of 50s and 60s, the gut dysbiosis becomes really prevalent. And it could be anything from, I feel bloated and occasionally don't feel well to like full-blown gut diseases.
Yeah.
Like that is kind of usually the first thing we see. Or as I mentioned, like the iron deposition, this marker would be elevated, or things, excessive BMI, heart disease, liver disease, kidney disease, things that cause chronic inflammation, this marker will be elevated. So I like it to be about, so this actually kind of is binary, so I like it to be between 40 and 60, so you look perfect there. And the last thing is T cell proliferation and survival. So that is the first thing that the immune system does. So when it sees the danger, it responds and proliferates to make cells to respond. And so that, I like it to be about 90, like between 85 and 100, let's say. So yours is a little low. And a lot of times, so your immune system cannot respond quickly. Once it responds, it's good because exhaustion is low. So once it responds, it's going, but it has it's a slow start. And a lot of times that's connected to sort of amount of stem cells you have. So it's sort of stemness issue. And so you either don't have as many stem cells or they're not as good. So like mitochondria is impaired. And so there's just sort of, they don't have enough energy, so they don't respond quickly. So that is something that and then again, sort of like, I hope you appreciate that ILS of 64 in you versus ILS of 64 in me could mean completely different things.
Got it.
So you really have to think of where the deficiency, if there's a deficiency, where the deficiency is, to target the treatment, because that is the best way to actually improve something without, the different things. And so, so I would say for you, that is probably if like, as far as improvement goes for the immune system, this and the cellular senescence piece, those are the areas for improvement. And in the cellular senescence, I would just say that we routinely see senolytics increase cellular senescence, and sort of therapies that people think are senolytic increase cellular senescence instead of decreasing. So it's, one has to be careful. And first of all, actually make sure we need it, but also, if you test, and if you don't test, you don't know.
Right. So it could be, even some of like the spermidine and FOXO4, like I mentioned, that could actually be doing the reverse, because maybe I didn't need the cellular senescence because I didn't have the data.
Exactly. Well, and autophagy is really important for senescent cells to kind of stay senescent.
Yeah.
But if you already have a lot of senescent cells, I mean, again, it's a balance, right? So you sort of, autophagy is really important, but too much autophagy is also bad. So it's a really nuanced picture. Immune system is really complex, and so to knowing which lever to pull is really important.
And you mentioned my inflammatory markers generally are low, which is
Yep.
great because over-exercise is something I do impose upon myself because I love exercising and
So is it consistent with sort of how you think of your chronic inflammation? Is it like low level? Is that consistent with how you feel?
yeah, yeah, from a blood perspective, my gut, my inflammatory markers are very low right now. That hasn't been the case historically, but if you go back in my 20s and 30s, very high inflammatory markers. And so I have
Yeah, exactly. We see it even in young people. Like it's not. I mean, yes, the immune system breaks with age, but it's a lot of times it's not age. Age is a very small component. A lot of times it's
yeah.
that's what things.
And then as far as the stem cells go, I mean that's something I do administer stem cells about every 6 months, doing intravenous. It seems like I may need to increase my quantity and see if I can bump that up. And is there any other things that you've seen that could actually interventions that I would want to experiment with?
So for T cell, like you're super optimized on the other two domains, so it's kind of hard to, you're limiting on sort of what you can. Like a lot of times we see people like kind of have, problem in all three domains. So then it's kind of you could do this, then you can do that. So you're pretty optimized in 2 out of 3. I think the things we normally recommend, like exercise, especially high intensity exercise ones, like you're doing all the things we typically do for mitochondria, right?
Yeah.
So it's like, eating well and sort of all the kind of obvious things for, what gives you energy. So I think for you specifically, might not necessarily be the same for your clients, but for you specifically, I think you're sort of limited in what you can do because you're already doing all the right things. Like lifestyle is the biggest, you're moving to cell proliferation, like the lifestyle exercise is the biggest thing. It's basically increasing your mitochondrial capacity. So that's the best way to do it, and you're already doing it and not overdoing it. So it's sort of you're in the sweet spot of, enough exercise, but not.
Yeah. And what do you see as far as like people using NAD or methylene blue? Does it change their results?
So methylene blue, I personally have very conflicting thoughts on methylene blue after all the papers that they stain your brain blue. So it's sort of, seems like we might find out things a few years from now that, we'll go, I can't believe we did that. But so we don't look at methylene blue because again, so we're collecting data, but it's really hard to do analysis because a lot of people doing a lot of things. And so nobody's doing one intervention. So it's really, so we need a very large data set to be able to tease these things out. So sort of, in general, we don't see like a big change when people go on methylene. We didn't see like a huge jump, but are they doing other things that are undermining that or not? I don't know. And then as far as the NAD, that's sort of, it has such a narrow, well, so first of all, NAD is a bucket, right? Like you can do NAD 15 different ways, and some of them work and some of them, extracellular NAD does nothing. Intracellular NAD actually, like, so it's sort of, so depending how you deliver, that might not work at all. So first of all, it's a very generic term that doesn't really mean much.
Yep.
But even if you do it in the right way and, your intracellular NAD goes up and all that, do you need that much? Because too much intracellular NAD is also bad for you because now your enzymes have to deal with processing all this NAD that they didn't need. So it's taking away from your energy chain because you're sort of employing the enzymes to break down NAD that they don't need. So you actually can cause a fatigue by overdoing NAD because your body. So it's sort of, so it's a, like, it's not, this is bad, this is good. It depends, right? It depends on who you are, where you are, and what you need. And I think I hope people in the space as we move forward, I hope the message sort of that, are you sure you need it? Not because your friend is doing, not because somebody, celebrity is doing it.
Influencer.
You need it. Because
Right.
it's, I mean, if the goal is to feel better and be better, you need to make sure you need it.
Yeah.
And
Well, I think Yeah, I think that's the biggest thing I've gotten out of this is the more the closer to the direct measurement you can get, the better, the more accurate it's going to be. And the farther away from these indirect measurements, you may be getting just noise. It may not be a clear signal. And then also looking at the interventions, because just because you feel good doesn't necessarily mean that you are on the longevity pathway. And some of the interventions may actually be overdoing it in certain areas. And so,
Exactly. And even not just longevity, but even the health span. Like it just because you feel better in the moment, it doesn't mean it's not breaking down your immune system and setting you on the worst path. Like feeling better in the moment versus 10 years from now is not the same thing. And so
yeah,
placebo effect is very much real. So it is sort of setting yourself up for success. And I also like when people ask me, so cellular senescence is very commonly upregulated when people are stressed. So you could be 40 and your immune system looks okay, but your cellular senescence is crazy. And so to the point where we think it's like somebody's getting chemotherapy, but they're super stressed, like whether it's work or it's home or they're just super stressed. And it's one of those things where you have to think about what is it in my life that could be causing this. It's like the pill is not always the answer. And sometimes, getting 8 hours of sleep and, letting things go is all you need. And I'm not saying that's you, but it's just
This is
but
important.
it's one of those things where sometimes it's a very simple. I mean, it's not, you can't sleep, but sometimes those very easy fundamentals that we all know we need are important. But on the flip side, if you're somebody who is not sleeping and having a lot of stress because something is happening at work, but your senescence looks fine, congratulations, you're getting away with it. Like it might not last, but for now, you don't need to implement all these things. If you need to make it through the next quarter, go for it. Like it's again, like we know what we need to do, but it's really hard to do all the things. And so to be able to understand where you are so you can prioritize things, I think it's really powerful.
I love that. And we've got to do a part B because now we've got brand new diagnostic data. And for those of you who want to really get fine-tuned on your longevity pathway and see if the inputs are actually yielding the results that we want, we'll be offering this test at the clinic. So make sure you just reach out to us. And for those of you who want to get in touch with Natalia and see what they're up to, what's the best website? I guess we'll provide links in the show notes, but
SapereX.com, the best website.
okay. And we'll provide that link, and you can find Natalia on LinkedIn, and we'll provide her handle there as well. Natalia, thanks so much for going through and researching this and actually finding some of the truth that us clinicians can start utilizing in our, in ourselves and our clients who want to live, really as healthy and well as possible.
It was a pleasure.
Thanks so much. Everybody, if you love this episode, make sure you share it with your friends, family, loved ones. Appreciate you guys.
Bye.